So, good afternoon, everyone. Myself, Dr. Vaibhav Goyal. I am here to present our study on impact of body mass index, height, and obesity on selection of skin entry points for transforaminal endoscopic lumbar discectomy. So, the contributors in the studies was the idea behind was by Dr. Prasad Padgaonkar sir, myself, Dr. Vaibhav Goyal, Dr. Utkarsh Nandan, and Dr. Vivek were also. I thank all for being the part of the study. So a brief history about endoscopic lumbar discectomy. It has evolved by leaps and bounds in the past decade. Visualizing and treating the painful pathologies through the transforaminal approach has created the space for diagnosis and treatment of degenerative lumbar conditions in a truly minimal invasive manner. So the history goes up to 1972 when Dr. Cambin introduced a posterolateral approach by defining the Cambin's triangle. What is this Cambin's triangle? It is a triangle over the dorsolateral disc with the hypotenuse as the exiting nerve root. The base is the superior border of the caudal vertebra and the height is the dura or the traversing nerve root. So here we can see the Cambin's triangle with the hypotenuse as the uh, exiting nerve root. The base is the superior border of the caudal vertebra and the height as the traversing nerve root or the durus. So since then, many technological advancements has given the surgeons to safely approach the disc through a percutaneous approach, endoscopical visualize the herniations and using specialized instruments to remove the offending disc fragment. But one of the most common cause of incomplete decompression even today is improper understanding of the skin entry point, which causes inability to access the epidural space. The SAP often doesn't allow the proper confirmation of the targeted nerve root decompression by direct visualization. So usually what we draw in all our cases is these four entry points, 1, 2, 3, 4. This is the 45-45 entry point. This is as we go from the midline more laterally. The second one is the posterolateral entry point. This is the posterolateral entry point. The next one is the tip of spinous entry point. And the last one is the dorsum of facet. How do we draw this? We'll come to this later. So the popular posterolateral entry point often fails to visualize the traversing nerve root without the wide foraminotomy and anelectomy, whereas the far lateral entry points, that is the TOSP and the DFJ, they can help visualize the traversing nerve root with minimal foraminotomy and anelectomy, but with high chances of exiting nerve root injury due to the direct pressure of the tang of the outer sheath. So this is a image describing how usually Young's method of drawing the posterolateral entry point. So what is the need of this study? What is the thought behind the study was, can the entry point be the same for all the patients? You can see the two men standing, one on the right and the left, thin and fat. Can the entry point be the same for both the patients? Purpose of the study was to determine whether physical parameters, including the body weight, height, BMI, and the girth, can affect the point of entry for TLD. We also aim to determine the safest entry point, considering the frequent site of compression, which are the central and paracentral disc herniations and the lateral canal stenosis. So we had 174 surgical cases prospectively analyzed over 2 years, 91 males, 83 females. In all the patients preoperatively, VAS, ODI score, neurological status, dynamic flexion extension X-rays was done to rule out instability. Height, weight, abdominal girth, and BMI were recorded for all the patients. All the patients underwent transforaminal endoscopic lumbar discectomy, that is TLD, under the monitored care anesthesia with 1% preservative-free lidocaine in prone position under the image guidance. So inclusion criteria were unilateral radicular pain or the discogenic pain, central paracentral disc herniations, and the lateral canal stenosis from L3 to S1 corresponding to the neurological findings, positive nerve root tension signs or neurologic findings corresponding dermatomal numbness or weakness, and all the patients had failed conservative trials for 6 months. The exclusion criteria were the central stenosis, foraminal extraforaminal herniations, listhesis with instability, and the patient lost to follow. So first, with the yes geometrical technique, the PL and TOS 45-45 entry points were marked. In the lateral images, TOSP and DFJ entry points were marked. We also marked a fifth entry point as the PL and TOSP, which is the midpoint between the PL entry point and the TOSP entry point. And this PL and TOSP entry point was used in all our cases as the entry point. So this, the top of the image is the midline, midline part, and the bottom, as we come to the bottom, we are coming laterally. The left side is the cranial, the right side is the caudal part. So as we come laterally, the first one is the 45-45, then is the posterolateral, then PL-TOSP, then tip of spinous process, and the last, most laterally, is the DFJ entry point. So this is how we mark the skin entry point. On the extreme left top is the A, figure A, demonstrating the midline in the AP view. Figure B demonstrating the level of the disc, horizontal line, again on the AP view. Figure C demonstrating the PL entry point in the lateral view along the disc inclination line. We measure the distance from the midline to the disc inclination line. Another D image, the 45-45, which is at the middle of the disc inclination line, and this distance is also measured from the midline. The E and F, the dorsal of facet joint and the tip of spinous process, is directly marked on the lateral views. So using the standard decompression technique was done, and the end point was considered as the confirmation of the pain relief, as the patient is under local anesthesia, fluttering of the epidural fat from the tip of superior articular process to the middle of the caudal pedicle. That is the extent of the nerve root, and the visualized decompression of the traversing nerve root. So what results? The mean height and weight was 162 and 69. Mean BMI and girth was 26 and 88. Most common posterolateral entry point was between 10 to 13. Most common TOSP entry point was between 13 and 20. VAS score decreased from a preoperative value of 7.9 to 1.84 at 6 months follow-up. ODI improved from 72 to 16. The increase, the main point was the increase in the statistical analysis, the increase in value of all the 4 entry points, that is 45-45, PL, TOSP and DFJ, was observed with physical parameters, and this change was statistically significant with a p-value of less than 0.0001. The complications rate was as usual, as we recurrence in 4%, dysesthesia 1.7, revision in 1.14. There were no discitis, motor weakness or durability. So the point to be discussed to be here is that statistically significant increase in distance from midline of all 4 entry points with physical parameters. Hence, one static figure of an entry point for all the patients cannot be used. This is a figure demonstrating the skin entry point distance from midline, which is changing with weight. So in the top, you can see in a 45 kg male patient, posterolateral entry point is 9.5 centimeter, whereas in a 125 kg it is 12.5 centimeter. Whereas a TOSP entry point in a 45 kg is 11 centimeter, whereas in a 125 it goes up to 18.5 centimeter. So there is a significant difference of entry point distance changing with weight. In contrast to the fixed entry point posterolateral, we found PL-TOSP was safe and accurate. Why it is safe, that will come in the next slide. Using that entry point, direct visualized nerve decompression of the nerve root could be achieved in all the cases. The angle of PL, posterolateral, the angle means the trajectory of this needle and the scope or the tang increases with weight, whereas TOSP angle decreases with weight. So when we mark a PL-TOSP entry, more or less the changes with weight is the same. Irrespective of the change in the physical parameters, the PL-TOSP trajectory remains least affected. So this is a figure demonstrating the PL and TOSP entry, how it changes with weight. Then a 45 kg, the PL posterolateral trajectory angle was 30 degrees, whereas in a 125 kg, it goes to 35 degrees. For a TOSP entry, the 45 kg patient, the trajectory was 25 degrees, whereas it has reduced to 15 degrees in a 125 kg patient. And if you look for the PL-TOSP trajectory, it is more or less same, 27 in 45 kg and 26 degrees in 125 kgs. So the take home message By this study could be the entry point is not a fixed value as it varies with the physical parameters like weight, BMI, and the girth of the patient. And the PLTOSP entry point is the safest and least affected with physical parameters for lower lumbar pathologies like central paracentral herniations and the lateral canal stenosis. Thank you so much for the pleasant hearing.